All right, so it looks like everybody was able to join, so I'm just going to start. So thanks to Nick and Gina for setting this up. So for those of you who don't know me, I'll give a little bit of an introduction to sort of how this talk fits into the Grand Round series. My name is Damian Rose. I'm a faculty member. I'm based at Langley Porter, although mostly based at home right now, of course. And my clinical passion is working with young adults and families, in particular, young adults and families that are in high levels of distress with sort of hallucinations, delusions, and some changes in cognition being some of the most common types of distress that I manage. And I've really come to believe over the last sort of 5 or 10 years that I've been doing this work that the system of care and the way that we define in particular psychosis, but I think my talk is going to be about DSM in particular, actually not only has some sort of logical problems and failings, I think it also, in a sense, pushes us to collude with an unjust system. So I'm going to start sort of with kind of 2 parts to this talk. So the first part, which is the invitation to bias, is talking just about how we use DSM and some of the assumptions of DSM and some of the problems with the way that we apply it and define it. But I want to sort of start with just a common language that we use. And Dr. LaWanda Hill, who spoke a couple weeks ago on anti-Black racism, I thought she really struck me with this. It's an important point when we use this sort of noun version to describe people. So we often talk about at-risk youth, or we talk about at-risk communities, but it sort of gives this idea that somehow at-risk is a quality that exists within a person. And I just want to quote here, this is from a child psychiatry journal, but you know, questioning this language, I use it a fair bit myself, at risk for psychosis, or youth at risk, clinical high risk. But I think it's important that we shouldn't forget that whenever we're talking about somebody at risk, we have to think about who's putting them at risk, right? And in particular, the systems that we're a part of, right? We have a lot of power and authority as clinicians. The systems that we're a part of, how are they actually contributing to the risk that certain populations are put at, and what should we do about it? So I'll just start by giving a little bit of a preamble, because this talk is technically the second in the Bay Area lecture series. The first was Dr. LaWanda Hill. For those of you who keep track, maybe not that many, we're actually not going to do clinical case conferences this year, or you might say this is the clinical case conference that we're going to do this year. And that's because in the spirit of a department that's moving towards an explicit anti-racism curriculum, the Bay Area, the Grand Rounds Committee, so myself, Lydia Santiago, Bob Hendren, Gina Martinez, and Ken Epstein, we tried to formalize a little bit more specifically. So not just 1 and 2, these are our goals for the Bay Area lecture series, but also that we wanted all of our speakers to explicitly speak to issues of social and environmental justice and racial justice. And I want you to think about sort of this talk in that vein. I'm going to talk a lot about DSM, but I'm going to talk about it in a social justice frame, and in particular, try to point out areas where it may actually lead to collusion with social injustice. So just to start off with the basics, I don't have anything to disclose for this talk. I have no formal stake in the DSM. I'm not betting against it or anything like that financially. But I have a request for the audience members. And I apologize, it's always awkward when I can't see you all. But this is a personal request, and I'm gonna try to do the same thing myself. And because I'm gonna be talking about something that I think most of us or all of us use every day, a diagnostic nomenclature, I really want us to catch ourselves if at any point during the seminar we stop and say, well, I know better than that. So I understand that the DSM has limitations. I account for those limitations. I get to know my patients deeply in a way that the DSM doesn't. Those statements may be partially true. And again, I'm speaking for myself here as well. But my fear is that this idea that because we're well-meaning people who want to get to know our patients, that we'll somehow protect ourselves from the biases inherent in the diagnostic nomenclature, I think is problematic. I think we all need to realize that just by the very fact that we use DSM day to day, that frame may actually be a collusion frame, whether we want it to be or not, whether we can take some perspective on it or not. So because of this talk gets pretty serious, I actually wanted to start with my joke slides, but the joke slides actually anticipate some of the issues that I'm going to bring up. So the first issue, I think, is just the human condition is one of suffering and distress and joy and wonder, all mixed into sort of one package. And so I think I want to sort of identify one of the issues with the diagnostic manual is that it's trying to capture this problem. So just to be kind of silly about it, I often wonder if DSM's first diagnosis shouldn't be this. Human condition personality disorder, which of course can't be due to a substance or a general medical condition, but consists of at least 2 of the 3 following criteria. Right, so this is a little bit dark humor. I'm poking fun at something that relates to suffering, but I think the point here is that we're all struggling with these issues. And one of the background themes here is going to be, at what point does the human condition become a disorder? My second joke slide is actually related to how I think we approach medication in this frame. So the onion, I think, sometimes captures society's failings the best. Right, and I like this last quote from Prozac. Right, I'm supposed to go in there and turn everything around without any support from loved ones or the system, right? Right. So, and I think this is a joke slide, but I think sometimes we actually use medications this way. Like it's what we can do, so we're going to do it, even though we feel like maybe we're kind of throwing it sort of just into some other issues. I'm going to come back to this one because I think this is where some of the assumptions of DSM really play out, is in medication use. And then if I was going to summarize sort of the last sort of 40 or 50 years of hopes for DSM, I think a lot of us have been told, well, let's just wait for the biomarkers, right? You know, it'll be okay. The neuroscientists will find biomarkers for us for all these disorders, and then we'll be really able to apply them. But I might, like the Dark Knight here, I might say, actually, the biomarkers here are irrelevant. Whether we find biomarkers or not is not the issue. The issue is, how are we framing human distress as something that exists inside the individual and that is a clear deviation from some optimal brain function? I think that's the issue here, not whether we'll eventually find biomarkers or not. I think that's beside the point. So I want us to think about this biomarker idea as a distraction from the issue of how DSM sort of affects social justice issues. So I just want us to pause for a second. I think most people probably recognize where this image comes from. This is September 9th of this month. So this was Dark Wednesday. And so I just want us to take a second. So for those of us who were in the Bay Area, or maybe just who live in the Bay Area and were away but saw photos, and just think for a second, you know, sort of seeing this, or maybe if you weren't able to see it, you know, hearing about it, or maybe you had a somatic experience that day. I certainly had a somatic experience that I just wasn't waking up. Just sort of maybe in the chat here, just write a couple of words or phrases that just come to mind when you think about your experience on September 9th. We'll give it a minute or two. And just so you know, I think you can say from anonymous if you'd like to. That's my understanding. I apologize if I'm wrong. Right. Scary, awe, doom, apocalypse, disorganization, disorientation, right? Fundamentally different, some sense of self-experience. I don't feel right, I feel off, I feel different. And then of course, what does this portend? And so I bring this up because, you know, because this was such a powerful sort of obvious expression of climate change, I think, you know, it really sort of pushed a lot of us to sort of have a shared experience, a shared negative experience. And I've been interested, it's been interesting to me how both the popular press and then to some extent, even sort of the opinion leaders in our field, how they've sort of dealt with this kind of new collective experience, not new, but shared at a level that it hadn't been shared before. And I think a common thing that people would say would be that these reactions, so people might say, this is a normal reaction to an abnormal situation. They might say something like, well, we shouldn't pathologize that. So we shouldn't call that mental illness. And I mean, I guess I agree with that, although I'm gonna catalog that. I'm not sure what we should call mental illness, period. But so I agree with that. But I think whenever I hear these things like don't pathologize normal, it always brings up this, I think there's a social justice issue, a second question packed into don't pathologize normal. And that is, well, when should we pathologize then, right? If you're telling me what not to pathologize, at what point do I pathologize? And so I want us to keep that in mind. And then a later question will be who gets to pathologize, but we'll come to that. So I'm gonna sort of split this talk into two parts. The first part here will be probably how I would have planned this talk if I would have given it 6 months or a year ago, maybe before COVID, before climate change, and before our department, I think, took a what I would consider a powerful, explicit stand against social injustice and racism. Not that we weren't taking that stand, but I've been very impressed by our medical schools, the strength of the stand that we're taking. And so I think probably, if I'm going to be honest with myself, I would have taken a little bit more of the poking fun at DSM approach, or would have tried to sort of, you know, catch it in its logic traps. And so, you know, so the first part of my talk is, I still think that there are logical fallacies and I want to point them out, but I want the background to here be, how do those logical fallacies actually play out in ways that may harm people? So we're going to talk just a little bit, we're going to briefly talk about the core assumptions of the modern day DSM. I'm going to make the argument that we've been trying hard to justify these assumptions, and to my knowledge, I'd be happy to be proven wrong, but to my knowledge, no data justifies some of the core assumptions from 1972. We're just going to sort of have a little fun with what would happen if we defined a climate change anxiety disorder, right? I think you could certainly epidemiologically make an argument for it. The question is going to be, how does that intersect with ideas of mental illness and personhood and society versus the individual? And then we're just going to talk about what are some of the logical conclusions of making a new diagnosis like this. So we're just going to follow the same logic that DSM uses for all of its syndromes, and just use it as sort of a pertinent recent example as what happens if we make a new diagnosis. What are the implications of it? So I'm going to talk a little bit about the core assumptions. So this is going to be a little bit of a history lesson. So my apologies. This is of course my take on the development of the DSM-III, which is probably the modern day DSM, starts with the DSM-III. And so I think that if you sort of take the long view and you look at psychiatry in the early 20th century versus the late 20th century, I think what you see is that the 20th century in the United States is really, a lot of it is about the rise of the authority of science. And a lot of work is put into how do we operationalize science, and in particular, what counts as real science. And I think how psychoanalysis kind of fits in is that psychoanalysis actually becomes, for a variety of historical reasons, the preeminent post-World War II academic psychiatry sort of frame. And that's actually different in other academic specialties. Are actually they're more becoming led by researchers. They're becoming led by scientific researchers within their departments. And so it creates this tension between psychiatry and the other fields. And I think, this is my opinion, but I'm happy to discuss it with folks. I think psychiatry got to feel a little bit behind or embarrassed, or whatever the right word is, by not having a nomenclature that was quote unquote scientific. I'm saying this independent of what true science is. The perception, I think, was that the scientific rigor of our nomenclature needed to be bumped up a notch. And so I think there was kind of a rush to DSM. And DSM has, I think, has a lot of hopes that it would be a set of disorders that would be sort of scientifically rigorous. So I'm gonna list them for you because these were all discussed in the 70s. These are originally called the Finer criteria. But when these syndromes that we now call mental disorders were first being codified in the 70s, remember, and they sort of reached their sort of zenith in 1980, and then they don't change much from 1980 to now. Most of our diagnoses are pretty much the 1980 definitions. So their hope was that, well, if I'm going to define a syndrome, the symptoms within it should be unique. There should be consistent epidemiology. There should be a consistent response to medication. There should be a consistent course and outcome. There should be increased heritability, and that we should be able to find specific genetic susceptibility loci. These were the hopes. This was the idea. This is the sort of statistical manual, right? Is that maybe we're going to be able to do this. The problem is, and part of it probably just comes from the hopes being a little bit too high for a syndrome. And part of it comes from maybe just the sort of, I don't know, strength of conviction that the people who came up with the criteria had. Really, at best, I would say these have sort of panned out to be somewhat true. So the problem here is, though, even though a lot of our disorders show consistent epidemiology and course, some of them, of course, don't. But so you get some predictions from DSMs. It's not too bad. I often feel schizophrenia, which is my world, gives some predictive value. I'm going to put a side note here. You do see increased heritability, but the problem is that heritability is not specific. And so what you see is that a lot of severe distress tracks in families, but the type of distress is usually not specific. And I want us to poke a little bit at this one because I purposely said that this one is not actually where DSM delivered. But what always strikes me is that we act like DSM delivered here. So it's embedded in our entire treatment nomenclature is predicated on the assumption that our medications are specifically treating syndromes. Antidepressant, antipsychotic. We're very much naming our drugs as if they specifically treat some underlying dysfunction that is genetically or biologically related to the syndrome. But remember, we haven't really been lucky at finding any genetic or biomarkers. So this assumption starts to fall down immediately. But I want to point out a logical fallacy that I think does a fair amount of harm. So I'm not going to talk about too much. I'm not going to talk too much about types of social injustice. This talk is a little bit more the longer view, but I do think it's worth speaking specifically to medication overuse. In my world, I think it's a huge problem. And I would call it a problem that intersects with social justice issues. So who gets more medication, how much more medication they get, and there's the assumptions we make about who needs medication. But all of them tie back to the assumptions that I told you about DSM that turned out not to be true. But we still follow this logic with medication use. We say, well, deviant behavior due to a mental disorder is more biological than deviant behavior that's not due to a mental disorder. We make that assumption. Therefore, biological deviant behavior is going to respond better to medication than sort of just basic bad behavior that's non-biological. And our medications are going to specifically correct an underlying dysfunction that is present in people with particular types of biologically deviant behavior. In my opinion, this is, we do a lot of harm with these three assumptions, and they're all predicated on the DSM assumption that turns out not to be true, that medications have a highly specific relationship with syndromes. So this is a topic that I've done a lot of research on, so I'm happy to discuss it more. I think it's a problem, the way that we discuss medications as having a specific action in specific people. But I'm not going to talk too much more about it because I want us to take some other longer view approaches too. But I do feel like one in my world, it causes a lot of harm, the overprescription of antipsychotics, with the assumption that we're correcting a deficit. So I'm going to come back to our climate change anxiety disorder. And then I just want us to say, just use an example. I'm going to use the DSM's own language. And we're going to say, what does it mean for us to put a new disorder into the DSM? What are the implications of that? And so I sort of put this ahead of time, but I might put in some of the words that people put into the chat, right? But of course, this can't be due to a substance or an underlying general medical condition. We always have to say that. But what if we defined people who, let's say now it's been 2 weeks. What if there were people who had persistent despair, worry, or fear related to the current and future effects of climate change? And that was present most of the time for at least 2 weeks. Now let's say that there was also, let's put doom and disorientation in there too, right? Despair, doom, disorientation, worry, or fear. DSM often does this. It packs several adjectives into a criterion. And then you just have to have at least 3 of the following. So intrusive images of climate disasters for an hour a day, excessive tracking of fires, floods, and/or air quality online, either the inability to fall asleep for at least an hour or the inability to get out of bed, right? So let's say you need at least 2 of those. I should have said 2 instead of 3. So from an epidemiologic standpoint, remember where DSM delivers, I probably would actually capture a group of people that have some similarities. So I might capture people who have a predilection to anxiety in general. I may capture people who obsessively track politics as well as obsessively track fires, floods, and air quality. I might find some interesting correlations. They might have some value. They might actually give me some predictions. I might be able to predict who's going to be most sensitive to climate change anxiety disorder. So it's not totally useless to define it. But I just want us to think about the consequences of calling this a mental disorder, right? This follows all the same criteria that a DSM-5 disorder would follow. There's nothing particular, and I think we would all agree that we can imagine this being a problem, right? We can imagine this being somebody who would seek sort of, some sort of solace or treatment, or however they sought that. And so actually, I'm seeing the chat question here actually anticipates where I'm going to go. And yes, so this is the issue. And the reason I explicitly chose climate change anxiety disorder is that all the DSM disorders hang on normal cultural response. So which is interesting. I'm just going to remind everybody that that means normal dominant culture response, right? That's how it's going to play out. So I chose climate change anxiety disorder as my foil because I think probably most people agree that having a reaction to this would be normal. But think about all the diagnoses think about case conferences you've been in, where a lot of the conversation really just was a couple of clinicians with the authority to decide what is a bizarre idea and what is a normal reaction to stress. But DSM is very explicit about this, right? So just first, so if I define climate change anxiety disorder, and let's say it gets put into DSM, DSM explicitly says this, okay, this is pretty straightforward. Right? A mental disorder is a clinically significant disturbance in cognition, emotion, regulation, or behavior. Actually, the disorder that I gave actually includes both cognitive, emotional, and behavioral aspects. So it's getting at a complex behavioral syndrome. But then DSM sort of adds this, which I find problematic. So it says, well, it's not just that syndrome. It's actually the syndrome reflecting a dysfunction in the psychological, biological, or developmental processes underlying mental function. My problem with this is who gets to decide whether your climate change anxiety is a dysfunction in your psychological processing, right? And how in the world would he even measure that? Right? How would we decide that? And so the implication here, and I often when I talk to the trainees about this, I point this out, there's an implication here that there's an optimal human function and that somehow any significant deviation from this optimal human function is pathological. If you think about the human condition, remember back to the joke slide, and just about the extreme range of human behavior and also the adaptiveness of the human race, I find it very problematic to sort of argue that there's an optimal human function. Let's to use climate change anxiety. Well, maybe the optimal response to that would be joining a political action committee and checking the air quality 30 minutes a day, right? Is there an optimal response to climate change anxiety? And then I think this is also where DSM gets a little bit tying itself in knots, but I want to point out the consequences of this. DSM also makes an interesting statement, and this is related to to that chat comment. So it is not an expectable or culturally approved response to a common stressor or loss. remember what the implication here is that culturally unapproved responses are mental disorders. And the dominant culture is generally the culture that gets to decide what is an approved response. And DSM actually does explicitly mention conflicts between the individual and society, or something that is considered socially deviant. But they put an interesting sort of side note. What says, well, it's not conflicts between the individual and society unless that conflict is entirely the result of dysfunction in the individual, which is an interesting statement. I'm not sure that people are understanding the consequence here, but the implication here is that there are conflicts with society that exist entirely within an individual. I guess I can imagine that, or I can imagine some extreme conflict that mostly exists within an individual. But it's an interesting thing to say, that there's a conflict with society that could exist within an individual. It's kind of it's almost like it's just sort of illogical on its face. So taken together, a mental disorder then is a significant and culturally unapproved conflict with society that exists entirely within an individual, or it's a significant dysfunction and deviation from optimal human function that exists entirely within an individual. So I just want us to think about that, right? So I think climate change anxiety disorder I chose specifically because it gets at this what's culturally approved. But all of our disorders come up against this problem, right? That something is culturally approved or not, and something is deviating from some presumed optimal human function. So again, so sort of this is what DSM maybe delivers. And I think it's fair to say, and this was one of the early DSM arguments, I think it's fair to say that, well, at the very least, if we could show consistent course and outcome with high reliability, that would be a valuable thing. And I think in general, medicine would make the same argument, right? So there are lots of syndromes in medicine like migraine or metabolic syndrome where, you know, we don't really know exactly what's going on. We don't know what the causes are, but the value is that people can reliably make the diagnosis, reliably apply the criteria, and then we get some prediction on course and outcome. The problem is, though, like a lot of disorders in medicine, but I'm just going to focus on the psychiatric ones, you actually don't get that good of agreement between raters. So independent of how we operationalize criteria or how we use them, what you find is in the real world, you actually get very poor inter-rater reliability. So what this slide is just showing is that in the DSM field trials, which are basically if the same patient were interviewed by several different clinicians, what was the sort of probability that the first clinician's diagnosis would predict the second clinician's diagnosis? It's modified a little bit to get a kappa, so that's not exactly the thing. But what you can see here, I want to draw our attention to these down here, because these are major depressive disorder, generalized anxiety disorder, obsessive compulsive personality disorder, post-traumatic stress disorder in children. These are all very common diagnoses. And the inter-rater reliability here is pretty low. I did a little off-the-cuff calculation, and if you just take sort of the 5 sort of most common disorders, I think at Langley-Porter, which is bipolar, schizophrenia, major depressive disorder, and a couple others, you get a net kappa or inter-rater reliability of something like 35%. So I think that's another, and I think probably part of the issue here is that, you know, because DSM is trying to tell us that we have to decide whose behavioral syndrome is due to dysfunction. I think that's another issue that comes up that makes for poor reliability. So we're gonna shift gears in a second, but I just want us to sort of challenge this logic of DSM. So if we take everything together, right, according to DSM and its logic for putting something in the DSM, it's some deviation from optimal human function that is culturally unapproved, for some reason requires medication more than a culturally approved deviation. That's implied, although never been demonstrated. And nobody can agree on who has one, right? So I think this is, so I often, you know, I often, when I talk about alternate diagnostic systems with folks, I often get, well, you know, but it has to be better than DSM. And I'm like, well, it's pretty low bar to be better than DSM if you're thinking about the value of diagnosis. Now, this is a little bit of a side conversation, but I do want to say DSM has it's a hard task. And part of the problem is that society applied DSM in a way that probably even its founders didn't want it to be applied. But in a sense, that's part of the problem, is how we're letting it be used. So I'm going to shift gears a little bit here. You know, I think sort of if this had been a talk I gave a year ago, I probably would have taken the left path here, which was more worn or more comfortable, something that I would, you know, had thought a lot about. But I'm going to challenge myself and us to sort of maybe take a second path, and that is a harder and a newer path. And that is that not only might DSM's sort of illogic lead to problematic diagnoses and unreliability and maybe medication overuse, but it actually may be actually inviting us to injustice writ large. And so I want us to focus on just sort of a couple of themes that come up for me. These are relatively new themes to me, so I invite folks. I want to be part of a conversation. I'm not here to tell you I know the answer, but I do feel like from a learning objective standpoint, I might make a little bit of a stronger learning objective than identify logical fallacies or understand the consequences of a DSM diagnosis. I might say something a little bit stronger like this. And this objective is informed a lot by my experience as a local schizophrenia expert. I'm often, I guess I should say I'm still surprised. I'm still surprised how many times somebody is referred to me and the question is this: does this person with hallucinations, delusions, 1 year of cognitive and expressivity decline, right, and school failure, does that person really have psychosis? I'm always struck by that question because by DSM definition, they would meet criteria for schizophrenia spectrum disorder. But I'm interested at sort of who gets to ask that question separately of me, who makes it to me, why do I get to be the final arbiter of this? Why do I get the authority to decide that, well, your psychosis is actually in you. This is not a reaction. This is not a normal reaction to something. This is psychosis in you. And then I don't have to back it up in any way whatsoever, other than it's my opinion. I don't have to demonstrate, I don't have to prove to you why this is real psychosis. And that has real consequences, some of them positive and some of them negative, but real consequences. And I'm just struck by that. And so I want to challenge us all to realize just how much authority DSM gives us, whether or not we want it. And we can't get away from that authority because we have to use DSM. And so we have to apply that authority. But I think we have to stop accepting that that's okay at the very least. And then my second learning objective comes from, I've been heartened, you know, I've been giving DSM talks for a while. And what I've noticed, especially over the last 10 years, is there's been a real increase in trainees struggling with the social justice implications of the way that our system diagnoses and treats folks. And so I want our second learning objective to be listen to the trainees, because this is what they say. This is an actual direct quote from a trainee that I just pulled from an email. So this is what our trainees are telling us, and this is what we need to worry about. Right? We're given this authority to medicate social issues. We're given this authority to criminalize behavioral disturbance. That's a lot of authority. So we need to start asking the question, even if we're well-meaning, are we sort of pointing our energies in the wrong direction? And so instead of a joke slide for these learning objectives, I just wanted to show this slide. Probably folks have seen some version of this. This is just showing that if you have 4 or more adverse childhood experiences, your sort of relative risk or odds ratio of also having a huge array, these cut across medicine, a huge array of negative outcomes. Because it's my world, I also add in ever hallucinated, because sometimes people think hallucinations are more biological and less subject to stress. That doesn't seem to be the case. So the reason I put these up here is I just want to think, if you were designing a healthcare system that was addressing some of the largest effect sizes, you would have to look at this and say, just in terms of the person years of suffering that I'm talking about here, right? This has to get our attention. I understand that we can't all address these directly. These are hard to address, but we shouldn't be pretending that if we address an individual dysfunction inside somebody who suffers a stressor, that somehow that's going to be the sort of best way to approach these problems. I don't mean it can't be helpful. Of course it can be helpful to treat somebody at the individual level. And I think a lot of people appreciate that. I'm thinking about mental health as a whole and the frame that we use, that we're waiting for people with brain dysfunction to come to us so we can fix the brain dysfunction and sort of send them back out into the world. And so again, to bring us to this sort of question when this sort of extremely abnormal response happens, and the answer is sort of, well, try not to pathologize normal reactions to abnormal stress. And then the question comes, well, then when should I pathologize? Apparently a culturally abnormal or unapproved reaction would be when we should pathologize. Or if we make some assumption that your reaction is due to something inside of you. I've seen this in the popular press sometimes too, that maybe climate change is exacerbating an underlying anxiety disorder. I find that interesting, the way that we're talking about it, right? And then this is the question I really want us to struggle with, right, at the end here. Who has the authority to pathologize? And is that authority justified? Because we don't really need to give any evidence for calling something culturally unapproved or evidence of I think we use this term underlying, evidence of an underlying problem. And so I want us to sort of struggle with this question, which is, you know, who decides what is culturally unapproved and who decides what is sort of suboptimal brain function? DSM sort of addresses this. I mean, I think probably our society just says if you have some threshold level of training and you use the DSM, then then you have that authority. And so I would say that it requires clinical training to recognize when the combination of predisposing factors has resulted in a psychopathological condition is a little bit unsatisfying to me. But this is what DSM says. DSM says that, well, because you had some clinical training, then you get to decide what's culturally unapproved and what is a suboptimal deviation from normal brain function. So I think, so just to sort of use our climate change anxiety disorder, if I diagnose you with it, meaning I think you're having a culturally unapproved response to climate change, you know, I wouldn't have to justify that in any other way other than I had clinical training, right? That would be my justification. So I'm struck by the level of power that implies, and that's part of what I think is the invitation to injustice, not just to bias. And I want to end just by thinking a little bit about what our trainees are telling us, right? So our trainees are telling us that they're concerned about, this is what they're seeing. This is their experience of a lot of the systems of care that they work in. And so I think we just need to question this framing of pathologies existing within individuals, that our diagnoses sort of extricate individuals from their social context, or maybe we think about you have an underlying problem and it intersects with the stressor in some sort of, I don't know, unbeknownst to us, sort of how to describe way. And that we just sort of, we don't mean to do this. This is why I say check ourselves and say that, well, I don't do that or I know better. Of course, we don't mean to do this. But I worry that we're systematically ignoring explanatory models in sort of the way that DSM sort of forces us to define things. And then I think this one This one I think is getting more attention now, and I think it's important. But you know, I think you can't ignore the power differential that's related to who's likely to receive a diagnosis or multiple diagnoses and who's likely to give a diagnosis or multiple diagnoses. Right? And I don't just mean the power between the clinician and the patient. I mean the power of the systems, et cetera. And so I like this quote because I want to use this word collude. So I'll let you read this quote. Because I think it gets at something that I had a hard time putting into words, and the trainees, I think, have pointed this out to me. It's an odd position to be in sometimes, to feel like you're striving to care for somebody. You're striving to care for somebody, but the context in which you care for them and the way in which they enter and leave your care actually either perpetuates or maybe even exaggerates some of the inequalities. And so it's almost like in order to give people care, we have to exaggerate some of the power inequalities. So I think the trainees are really struggling with this. Certainly I'm struggling with this. And then just to sort of make a larger point about the DSM frame. So it's not like DSM doesn't care about trauma or it doesn't mention stress as important. But I think the issue here is that, but in terms of operationalizing what counts as a mental disorder, right? It really sort of has really only a couple diagnoses that explicitly mention trauma. And then of course it has this odd sort of, I guess it's a culturally unapproved psychopathology that exists within an individual with PTSD that requires trauma. So it's kind of a tortured explanation about, as opposed to a quote unquote normal trauma response. But you know, whenever you study it, and remember the ACEs slide I showed you, you know, basically through meta-analysis, almost all of the sort of big impact, the high impact or common behavioral syndromes that are in the DSM are all tightly associated with childhood adversity and other types of trauma. And so this is, you know, this I think is just, it's an important frame problem that I think we need to address. And so I want to just combine two numbers, and I'm going to be a little bit fair here because I'm going to be mixing statistics. So I don't want you to take my number that I'm going to show you as sort of a comparative number, but I just want us to think about, remember that logical fallacy about medication use. So if you have real mental disorder, then you're more likely to have a biological problem. If you're more likely to have a biological problem, you're more likely to respond to medication. Again, each one of those steps has yet to be demonstrated. And so ergo, medication corrects a biological dysfunction. Again, that could be true. There's just no evidence that it's true for most of the patients that we treat. And so my point with this slide was to show you the high effect size of all of these different issues. So if we're just going to say at the global level, what affects outcome? Medication, if you really look at it, you know, I dive really deep into the antipsychotic medication literature. Medication is kind of about a 10% effect. And so I just want to sort of, if you were going to say, what are we doing? Again, I understand I'm mixing statistics here, but we're faced with the enormity of all of these outcomes, these effects. If we rely on medication as correcting a brain deficit, this is not an anti-medication argument. This is a statistical argument on applying overuse and misapplication of medication based upon a faulty assumption. If we just think of medication to treat an underlying dysfunction as something that we should be doing, we're having a very small effect. So I'm happy to justify this 0.9 number, but my read of all of the antipsychotic trials that I have read that have been published, at best you're getting about a 10-point reduction on the PANSS from 90 to 80. That's about the best you get with a medication effect, which is meaningful but small. And so I'm going to end just with a couple recommendations and just some ideas to think through. I'm purposely leaving 10 full minutes for comments. I also want to address some of them that I saw in the chat already. But I just want us to reject the idea that our treatments are correcting a deficit. Not that they couldn't. I can imagine a medication or even a specific psychotherapy, a behavioral treatment that corrects a deficit. But I think that if that's the frame of our treatment, it's just not going to hold up very well under scrutiny for the vast majority of the people we see. This assumption that there's again, this term underlying I always find problematic. You have an underlying dysfunction. This is not normal sadness. It's evidence of brain dysfunction. Maybe, possibly, but that's pretty hard to demonstrate, and it isolates the problem in the individual. I'm going to go big. This is not an easy thing to do. I actually would advocate for ICD dropping mental disorder as a category. I actually don't find it a useful category. I don't find mental illness a useful category, just like I wouldn't find physical illness a useful category. It doesn't provide much information. It implies that there's some shared optimal brain, that if you have mental illness, you're a deviant from the optimal brain, which I find a problematic assumption at the social level. There were a couple of discussions about the kappa scores and the criteria for MDD, so I'll address them now. I think behavioral syndromes certainly have value, but I think they should only be allowed if they're high reliability and if their component parts are tightly correlated. And that is one of the problems with major depressive disorder, is that it has a variety of criteria that probably are capturing 3 or 4 epidemiologic tracks that just happen to coincide in some people. But you have some problems with defining this. It doesn't give you much prediction when you go with symptoms that don't tightly correlate. I would just jettison disorder. I think it sounds too much like disease. And I think it's kind of a language trick to rename a syndrome as a disorder. Just call it, it's a syndrome. Just call it a syndrome. Disorder implies that there's a disorder in brain function, which could be possible. But to use the medicine analogy, I mean, I assume there's some disorder in metabolic function that underlies metabolic disorder, a metabolic syndrome, but I still call it metabolic syndrome, not metabolic disorder, because I don't know exactly what that dysfunction is. So I find disorder kind of cheating. And then I think this is where we probably all try to do this, but I want to think about this at the diagnostic level, not just at the interpersonal level. What is a way to have a nomenclature system that captures subjective narrative in some efficient, meaningful way? I'm not saying this is easy, but I feel like this at the very least will protect us from some of the more, I think, authoritarian aspects of DSM. And so I'll just end. I just want to sort of advertise these. I'm not experts in these, but I've been looking around. And so I think the power threat meaning framework, some people have been familiar with it. I think it's an explicit idea to sort of catalog. Of course, we need to catalog distress. I'm not here to say that cataloging has no value, right? Nomenclature is important, but what is the goal of the framework? How do we catalog distress, and how do we explicitly consider social context and experience in an efficient and reliable manner? And so I think, I would like to see a diagnostic system that talks about subjective experience and meaning making as just sort of part of the patient experience. And I want us to get away from this idea that DSM is more objective. I'm not convinced the DSM is more objective. I think that's a misuse of the word objective. And then this is just a comment because I've become more familiar with the restorative justice frame. I like thinking about the restorative justice frame in my work with patients and families now, right? So it's a way to reframe sort of moments of distress and distortion, just in a sort of what do we do about it now and how do we approach it as a community? And I think that's part of what I worry about in psychiatry, is that we're losing this approach these problems as a community aspect to dealing with distress. And I'll just end with my what if fear, and then we'll have time for discussion. But I think, what if one of the side effects of this process of extricating and isolating mental health problems is that we actually contribute to the competence of the community as a whole going down? with this idea that we're going to find the people who have individual dysfunction, treat them and send them back. What if we're actually working against the community's ability to do so? So I'll end there. I think if the simplest way to do this, my understanding is that if folks want to write in the chat, I will just sort of try to answer them sort of as they come. But thank you for paying attention. I know it was a little bit of me talking at you, but I'm very open to discussing these from a humble framework. So I think we have something like 8 more minutes before we have to stop. So I appreciate from Alice the reference. I do want to just, I do want to address Victor Roos's point. It is true, the kappas for DSM-5 were especially bad, probably for reasons that had to do with those field trials. My point was just that I think if we're going to use a behavioral syndrome, we have to get rid of the ones that have poor inter-rater reliability and keep the ones that have good. Otherwise, a syndrome loses its value if people can't apply it. Again, I would make that same argument across medicine. And then, yeah, Marty, of course, I agree that the use of the word formulation here is extremely relevant. So I often tell my trainees when they express these fears of sort of our, again, I guess medicalized is the way people would use it, although I'm not sure that's quite the right word. But I always say, you know, regardless of what else you do, you still have to formulate your patient's problems, right? And their goals and their strengths, right? And that's, in a sense, that's from an effect size, that's one of the largest things you're going to offer them, is going to be a formulation of their problem strengths and goals. Your medications will help. Your specific psychotherapy approaches will help, but they won't be the largest effect at the societal level. So I'm just going to, just because for reasons of time, because Thomas Zaz is a whole sort of talk in and of himself. So I do feel like aspects of Thomas Zaz is relevant to the talk. I'm not sure I agree with his approach to what we should do instead, but I think some of his critiques are still very relevant today. So to Jake's point, yeah, this is why I think this has to be a conversation. And you're certainly right that diagnosing syndromes in particular is a problem across medicine, right? And we're not the only field that may sort of perpetuate social inequity. Medicine authority is large and cuts across different demographics. And I agree, I don't think there's no perfect way to diagnose folks. But I would like us to be more explicit about what our goals are. And then just to use sort of a language that I found helpful when I'm dealing with psychosis. So, you know, if you feel like a behavior is deviant or problematic, and that's okay to say, right? That's fine to say that. And then you just don't say that because I think it's deviant or problematic, that means you have a brain dysfunction. I think that's the problematic authority that happens. Of course, you never get away entirely from cultural approval, but we should just take it head on. I often work with a lot of my folks who have, you know, schizophrenia syndromes, and I often use that. I just say, you know, you just have to realize that the way that you communicate is not the way that most people communicate. That's not fair, so that does mean it's, I wouldn't say culturally unapproved, but that's what we're talking about. So I think, Victor, I appreciate your keeping me honest. Yeah, I do. So genetic research has, of course, made advances, and I was being a little bit hyperbolic to say that DSM failed in its hopes. But I do feel like what you're implying too is that it's given us some hints, but I'm not sure that we couldn't have gotten those hints from sort of focusing on other syndromal ways of defining distress, in particular focusing on reliability and epidemiology and updating our reliability and epidemiology. So I can't speak to other training programs. My experience is that whenever I bring these topics up, most people have had at the very least side discussions about these issues, both attendings and trainees. I mean, just sort of, just to throw a quote out there, I often sort of have people tell me, well, I feel like what the system wants me to do is give a long-acting injectable to somebody who needs housing, right? I think that's a fair assessment of what the system is expecting us to do. And then remember, we're rewarded for that. This is where I think we have to check our own biases, even if I don't want to be. We're rewarded for that. So sorry, a bunch of things just came up all at once. So it's going to be hard for me. I just want to check out the time here. So we just have a couple more minutes. I'm just going to address two of them, and then I think we'll allow everybody to be sent on their way. So the issue, I think the difficult issue, and this is why I think this needs to be a conversation about sort of DSM. I think it's fair to say DSM represents a particular cultural framework, although you could say it's maybe even an extreme end of a particular cultural framework. It brings up the issue. I think the question here is how would you design a document that's flexible enough, right, but also efficient enough to capture culture in a meaningful way? I don't think we've tried. So I think that's the question. And then I'll just end because I think Descartes makes an important point. So there's in no way do I feel like there couldn't be brain dysfunction. Right? Of course, but I think at the current level of our understanding, my frustration is why do we get to say that you have a brain dysfunction without ever having to demonstrate it? I work with a lot of folks who had quote unquote normal cognition and then had a significant decline in cognition. So it's hard for me to say that didn't relate to some change in their brain. But what I would like to think is that we anchor the brain dysfunction around the actual problem itself and not around the syndrome. Right? And so we talk about what was the change in your attentional ability? What was the change in your working memory ability? What was the change in your semantic linkage ability? And I think that's going to be much more scientifically tight and much more amenable to having a conversation with the person. They're much more likely to agree with me than me saying, oh, by the way, you have a schizophrenia brain pathology, and that's the problem, and you need an antipsychotic to correct that brain pathology. That I think is an authoritarian stance that's not very evidence-based. All right, everybody, I said I would end on time. Thanks for listening.